Good afternoon and welcome to all of you who have joined us in this program. We are from Aster CMI at Hebbal in Bangalore, and I have with me Dr. Kayal, who is a gastroenterologist in my team, and I am Naresh Bhat, who is the lead gastroenterologist of our team. Inflammatory bowel disease, or IBD, is a problem that lasts for a long time, and there are several people who are afflicted by this disorder, and there are two key diseases. One is ulcerative colitis, and the other is Crohn's disease. Of course, these come not as two diseases, but various kind of expressions of these diseases. Some of them are milder, some of them are more severe, and some of them have some complications. And today we intend to spend the next half an hour or so trying to address some of the issues that people may want to know about in IBD or would have some points clarified from us. At the onset, one of the questions that we have is about what causes inflammatory bowel disease. So, Dr. Kayal, would you like to address that? Is it a kind of infection? What is it?
Okay, what causes inflammatory bowel disease? Multifactorial. There will be some element of genetic, some environmental factors, microbiomes, some say diet. So there is various factors that contribute to inflammatory bowel disease. And the simplest way to explain that is by saying that there is an excessive immune response by our body that leads to injury into the intestine, which causes ulcers. And this can happen in the large intestine, small intestine, stomach, esophagus, any part of the intestine can be affected and can cause ulcers.
So if a simple way to put it is, I always tell my patients, is that whenever you have a crowd, you have the police called in and they do a lathi charge or whatever. And when the crowd disperses, the policemen are expected to go back to their barracks. But if the policemen continue to do a lathi charge on people who are innocently standing, and that's exactly what our immune system does, because it's not regulated, it can cause injury to its own self, like the intestine, the large intestine and ulcerative colitis, and across the entire alimentary tract in Crohn's disease.
Yes.
So how important do you think is the role of genetics? Is it a disease that is largely run in families?
Not really. The contribution of genes to IBD would probably seen in less than 10% of patients. Very few. If you have a family history, then you have a higher risk of somebody getting it, but not all patients need to get it as well.
So the risk is about 3 to 5% at best.
Yes.
If someone in the family has. Of course, unless you have
two members of the family,
parents who have it, and then both parents have it, then obviously it becomes
the risk
more.
Is higher.
Or if you have a twin, and then it becomes more. But otherwise, the risk is there, but not huge.
Yes.
So what is this? We talk about this bacteria in the gut, which keep causing problems for so many diseases today, right from migraine to diabetes to cancer and so on and so forth. How important is this intestinal bacteria or the microbiome in the genesis of inflammatory bowel disease?
Okay. I will try and simplify this a little. See, all of us harbor bacteria in our intestines. In fact, the number of bacteria we have in our intestines are 10 times more than the number of cells that we have in our body. So there are good bacteria, most of this, and there are bad bacteria. These good bacteria, we establish a symbiotic relationship with them, and that keeps the immune system normal. When there is an imbalance between these two, that can contribute to inflammatory bowel disease.
Okay. So one of the questions is that I have IBD, I have ulcerative colitis. Can you suggest to me what I should do to prevent a relapse? Would you like to discuss this?
Yes. Few things, few important key points which we tell all our patients. One, avoid unnecessary medications, particularly painkillers. You have a headache, take a painkiller, stomachache, take a painkiller. Painkillers should be avoided as much as possible. Actually, I would say no painkillers for all patients with inflammatory bowel disease.
What about, say, drug like paracetamol for fever?
Yes. One drug which I would really say take if you really have a pain or fever would be a paracetamol.
So paracetamol is reasonably safe. Or drugs like diclofenac or those kind of drugs
should be avoided. Paracetamol is a safe bet that you have, and obviously it has to be regulated in consulting with your doctor. The other thing is antibiotics. As much as you avoid unnecessary antibiotics, good.
Why are you saying that antibiotics may actually cause an aggravation of the disease or a relapse?
See, there are various ways by which antibiotics can affect. One is it can alter the movement of the intestines per se. Second, like I told you, that good bacteria, bad bacteria balance, that can be disturbed by antibiotics. So all these things contribute to antibiotics worsening a disease if you already have one. So best avoid it. Take it only if necessary, and obviously again in consultation with your treating gastroenterologist. And another most important thing is smoking.
In fact, there's another question which is related to this, and she's asking, this is Suhasini, she's asking is doctors often make me do a test for something called Clostridium difficile. What is that and what's the relationship to this?
Yes, Clostridium difficile is a type of bacteria which causes worsening of a disease if you have, and it is most often caused by taking antibiotics. So it is a bad bacteria which is worsening your disease.
So are you trying to tell the listeners that if you have inflammatory bowel disease or IBD, taking unnecessary antibiotics would do a lot of harm?
Yes.
So antibiotics and painkillers are bad. What about drugs like Lomotil and Loperamide? Are they okay to take if someone has diarrhea?
This is irrespective of inflammatory bowel disease for any patient. If you have diarrhea, the common thing that we all have is go to a pharmacy, ask him for a drug which will stop your diarrhea and take. So the common thing that people use is L-Dopa. I think it should be avoided. It causes more harm than good. Most important thing is hydrate yourself well. If you have diarrhea, hydrate yourself well. That will be the most important thing. If it persists, visit the doctor, take medications, get yourself evaluated for the diarrhea, and not stopping the diarrhea by taking an L-Dopa or Lomotil is not the solution. It can cause harm.
Okay, there's a question from Harshit. Would you like to address
that? I think Harshit has this question about is IBD caused by too much stress?
Okay, that's a good question, Harsha. Earlier, about 30-40 years ago, we thought IBD, especially ulcerative colitis, was largely related to stress. And in fact, when I was a medical student about 45-50 years ago, we were taught that when you have stress, you bleed in the intestine. It's the tears of stress that are coming out through the intestine. But subsequently, studies have clearly shown that most patients with IBD do not necessarily have an underlying stress. But we do know that whatever disease it is, whether it is migraine, to fever, to cancer, to anything, is obviously going to be worsened by stress. So stress is not good for IBD, but it's not a causative factor. It's not that if you have 100 people with stress, then a large number of them are going to land up with IBD. That's not really true. But yes, it's not a good idea to be stressed in any case.
Okay. There's another question by Pradeep. He says, doctor is taking herbs, vitamins and probiotics. Will they help me improve my IBD?
An interesting concept that we're talking about. So far we spoke about If you have IBD, what gives you IBD? We spoke about the microbiome, we spoke about genetic factors, the unregulated or immune system which is sort of running amok and causing problems. Then we've spoke about what may be the aggravating factors. We spoke about painkillers, we spoke about antibiotics, and we forgot about the infections which can cause relapse. I mean, you can't have IBD and be eating pani puri and bhel puri somewhere else, because any amount of infections which you are exposed to is likely to trigger off your stress.
Agreed.
So again, infections again may need antibiotics, so it's a double whammy. So infections, antibiotics, and what is the
Avoid infections and smoking.
and smoking. Yes, smoking is again very, very important. So these are things that you would perhaps not be doing if you have IBD. But coming to the next aspect of what could be the positive thing that you could do, as Pradeep says, if I take a lot of herbs and vitamins and probiotics, will it improve my IBD? Well, the answer is yes. Certainly a healthy diet, a nutritious diet will go a long way. A balanced diet with enough vegetables and herbs which sort of contribute to good bacteria in the bowel is certainly a good idea to sort of aim for. Probiotics, there's a bit of a challenge. We do know that probiotics as a concept is good, but unfortunately, I don't think the pharma industry has been able to come up with an ideal probiotic for these patients. I think they are around the corner. Maybe in a few years, we may have special probiotics for patients with IBD. But as of now, in our unit, we don't really make a recommendation for probiotics. But a good, nutritious, healthy diet goes a long way.
So now, if we're talking of inflammatory bowel disease that we're talking, Dr. Naresh, what are the symptoms most often patients come to us with, and more important, what are the tests that you essentially need to diagnose IBD?
Yeah, I think, ulcerative colitis almost always comes with diarrhea, and most often we find blood in the stool, either at least on microscopy or the patient is able to see. And the typical story is, doctor, I need to pass motions several times a day, 4-5 times a day. I find a fair amount of mucus, maybe specks of blood that I see, and this has been going on for several weeks now. And I find that I go to the toilet and I have a little crampy pain, come out of the toilet, and again the pain comes back, and I say, I think I want to go back. So that's a typical story in patients with ulcerative colitis. The problem with Crohn's disease is a little different. Because here, you may have diarrhea, but may not be so sort of prominent. They may just have a little stool frequency, they may have pain, they may be losing weight, they may just have anemia. So it behaves slightly differently. So most physicians may pick up ulcerative colitis quite easily, but Crohn's disease still remains a challenge to most doctors across the world. And before, most physicians were familiar with these entities, even in the United States, it would take them 4 years from the onset of symptoms to diagnose Crohn's disease. But we've come a long way from that, and now I think in about 4 to 6 months, I think most of our patients with Crohn's disease have a diagnosis that is made. Dr. Kyle, can I ask you, how important is endoscopy in making a diagnosis? Is that, can you do an endoscopy and be very sure that there is...
Okay. See, for ulcerative colitis, yes, if I do an endoscopy, I'm reasonably confident that test is enough. But when it comes to Crohn's disease, we have to have a lot of other things. It's not just, endoscopy is an important aspect. You need to have biopsies So the pathologist plays an important role. You need to have a good imaging, a CT scan or an MR scan where the intestines are brought out better, something called as an enterography, which can be done with a CT or an MRI. So the radiologist plays an important role. The diet, what dietitians, nutrition that needs to be taken. So the dietitian plays an important role. So this teamwork is very essential in diagnosing. So you need to have a good endoscopist, a good pathologist to read your biopsy reports, a good radiologist and a dietitian. And obviously, I'm not leaving out the surgeon. Surgeon also plays an important role in managing inflammatory bowel disease.
I think you make an excellent point that for the management of IBD, we need a group of people who are committed and are experts in their area, and all of them contribute their bit to making a diagnosis. Because just looking on endoscopy, you can suspect but not prove. So the pathologist can tell us something more, but it is not just one test. I think often what we do is we all sit together, the pathologists, the clinicians, the endoscopists, the radiologists, and then sit and say, okay, this is what we find. This is most likely going to be Crohn's disease. So I think I can't overemphasize the role of a teamwork in making a diagnosis. I think everyone needs to put in, and you cannot have an isolated clinician sitting and passing judgment that this is Crohn's disease and thing. We need the help of a lot of people, and typically in our team, it's not just got me or she, but we sit together like this around a table, 4 of us or 5 of us, discuss the facts and say, okay, this is the best option for this patient. It's not only a diagnosis, but even the treatment plan. So I think that's a very important aspect that is you've been brought on.
Yes.
You also brought on this business about nutrition. Because nutrition is absolutely paramount in the management of IBD, because these patients tend to have a lot of nutritional problems. Having discussed this, would you like to comment on, we know that vitamin D is now the rage. Everyone is talking about vitamin D for everything, from heart attacks to everything, cancer and so on. How important is vitamin D and maintaining good vitamin D levels in IBD?
Absolutely. Vitamin D is absolutely essential. You must maintain it within the normal range. I always see patients taking vitamin D. It's essential. Keep it within normal range. It can be supplemented. But it should not be an overdosage as well. That is important that we need to look. It's not just vitamin D. It's your iron levels. It's your B12 levels. It's your zinc levels. All these micronutrients, that's the term given to micronutrients and vitamins. All these things put together play an important role. That is why nutrition needs to be really emphasized.
So our team has a full nutrition team within our thing to manage.
So talking about treatment, I have Subhash asking me, if someone has IBD, you'll have to have your colon removed. Okay, it sounds a little dramatic. I want Dr. Naresh to address it.
So, yes. Sometimes we operate patients, especially with ulcerative colitis. We do colectomies. These are usually patients who have long-standing disease or have complications of the disease and can't be managed with any other mode. We do know that a small number of patients with ulcerative colitis, if not controlled well and kept under what we call a remission, there's a higher risk of colon cancer. So those are the conditions that we really think of a colectomy. But by and large, our patients with ulcerative colitis do not need colectomy. Maybe, would you say about 5%?
5%.
Would be a reasonable number, may end up with a colectomy. But the colectomy is a reasonably good surgery for patients who need it. But I'd also put the other point that if you have ulcerative colitis and you keep the disease under control well with medication, and the term we use is keep it in a remission, your quality of life can be excellent, your lifespan can be normal, and you perhaps live with your colon all your life. So it's needed in a small minority for, when the other options are exhausted. But then when you do it, their quality of life is reasonably good even after a colectomy. So that's not a problem.
So you're talking about medications. So is it one medication, many medications, is it variations? Something that we would like to discuss for patients?
Yeah, even if I look at my own career as a gastroenterologist, when we started off about 38 years ago, we used to have very few medicines available for our patients. In fact, we hardly saw Crohn's disease at that time. We used to see some ulcerative colitis. But now we have a plethora of medications available for our patients. The basic thing is to keep this immune system under control and cut out the inflammation. So those are the two sort of cornerstones of therapy. So there are many drugs. So if you talk of ulcerative colitis, we keep the inflammation down with drugs like 5-ASA or aminosalicylic acid. That is the major drug. Of course, sometimes we need to use steroids to control a flare in some patients. Sometimes we use what are called immunomodulators, drugs like azathioprine, to keep them, if they require steroids often. We hate to give steroids often, even if we give it for a short period of time because they have side effects. So it's really not a good idea to take steroids again and again and again. So if someone requires steroids more than once or maybe twice, we use another drug which does not have the side effects and patients lead a good quality of life with that and prevents relapses. Of course, now there are a group of drugs which we call biologics. Many drugs like infliximab, adalimumab, and so on and so forth. The list is ever expanding. And we find these are especially useful in patients with Crohn's disease.
So when we start talking to patients about their disease, patients with inflammatory bowel disease, we talk about these medications. And one common question which I always face is, Doctor, how long?
Yeah, it's a question that's sometimes difficult to answer, especially when the patient has come to you for the first time. So generally we say long term. Why do I avoid the use of long term? Is because we know that some patients, the disease kind of dies down or just dries up over a period of time. So he may require medication for 5-10 years, and thereafter we may be able to get him off the medication, right? So I usually don't use the word lifelong, but I say long term. But the good thing is that if you've got the disease under control and keep it there, the quality of life is so good that a lot of patients say, Doctor, are you really sure you want me to cut down my medication? You're really sure you want me to stop the medication because I'm doing so good with it. Earlier I had so many symptoms, so many problems. I couldn't go to work. Staying at home was a problem. Managing home, talking about the homemakers, the women. So this has given me a great quality of life. My social life is so much better. So once you're able to achieve that, we find that our patients' acceptance for therapy is so much better. But yes, it's a challenge initially when they are resistant to take medication. But I'm sure a lot of our patients who are listening in will agree that medication, once you are used to it and it suits you, it actually does wonders.
So we have Pallavi who's asked, are there some medications that can get me out of a flare quickly?
Yes. So one of the drugs, when we have a flare, typically what do we do? Is the flare because the patient has he's got some other infection?
Yes.
Right, that's an important thing, in which case I need to deal with that infection. And one of the infections is maybe any other bacterial infection, maybe amoebiasis, maybe something else. So you deal with that. If it is not an infection, is it something like Clostridium difficile that we discussed? So that needs to be dealt with. Now, if these are not there and the disease itself has flared because of, say, painkillers or antibiotics or whatever, then of course the drugs that we use we use steroids. And because the good thing about steroids is that it acts very quickly and brings down the symptoms within a few days. But caution is that you don't take steroids on your own, because and you don't continue it indefinitely because they can have a lot of side effects. We've had patients who got quite used to taking steroids on their own and landed up with fractures of both the long bones of the legs, requiring hip joint replacement and so on, not realizing that there's so-called small dose of steroids that they were taking for several months would land them into such a bad shape.
So, Sabha has asked us, could any condition other than IBD be causing my symptoms? Sabha, for this, we'll need to see you, take your history, examine you, do a preliminary blood test at least to say whether this is blood test and stool motion test to see if this is IBD or not. Because lot of, especially in Crohn's disease, lot of other diseases can mimic inflammatory IBD. So we need to see you and evaluate you.
Yes, there are many mimics of IBD.
Many mimics. So we need
in fact, in our clinic, when patients come to us with a diagnosis of IBD, I think at least 30% of the time we tell them that what your diagnosed IBD is not tenable. Actually, you do not have ulcerative colitis or you don't have Crohn's disease.
So you will need
So I think we need to evaluate it.
Yeah.
Kyle, would you like to address this question about how long will IBD last? I think I referred to it, but would you like to again re-emphasize?
See, there are somebody develops inflammatory bowel disease. It can be, there are various stages. It can be mild. Some people have it moderate. Some people have it severe. People who have mild disease, we have seen that they do well with medications, and there are a small number of patients who don't come back again, who do well. But like Sir said, long term, I think that is where I will leave it.
So the mantra, I think there are a couple of questions, is nothing that can be done for IBD. Please give suggestions. Someone says, how to prevent bowel strictures if you are on a remission. I think really today, our key target is not just feeling good, that's a clinical remission, but to make sure that all the inflammation in the intestine has healed. And that is what we call an endoscopic or mucosal remission. Now, if you do not have inflammation, obviously the disease cannot progress. If you have inflammation, healing, fibrosis, it can keep on worsening and you can get complications. So to answer Venkatesh Prabhu's question, if you're on a remission, and we are not talking just clinical remission, not that you're feeling good, but if you're on a histological remission, if the bowel looks good on endoscopy, and on your blood test that we do, a fecal calprotectin, we do CRPs, things like that, if those tests are normal, then you can be sure that what you're doing is good and you're unlikely to get into problems in the future. So you aim for a mucosal remission.
Okay. So
and there are several options. It's not that nothing can be done. There's plenty that can be done. There's so many drugs. We have to choose what drug suits you best. So there are many options and we can give you a good quality of life.
I think to simplify it, it's like if somebody has diabetes, what's the question you'll ask? How long? You say you have to, the most important thing that we say is keep your sugar levels under control. Similarly, in inflammatory bowel disease, the most important thing is to keep the disease under control. That is what we mean by remission. Keeping things under control is remission. And we have various options available, medicines, various like if injections and if needed surgery. All this is to keep your disease under control and have a good quality of life. That is a key thing.
Kyle, a quick word on pregnancy and IBD. Is it that women who have IBD can't get pregnant, or their IBD is going to get worse? What is the risk to the baby? Would you like to allay some fears on this?
We have a lot of patients. Okay, I'll put it this way. We have a lot of patients who are diagnosed with IBD when they're quite young, and women who have gone through wedding, the pregnancies and children all doing well. But the key thing to all these patients is, again, like what I stressed is on, keep the disease under control. So if you have a good disease control, you can go ahead with pregnancy, have normal children. The effects on the children are very minimal. We have good medications which do not have any effects during your pregnancy or breastfeeding. So you can continue the medications, keep the disease under control and have good outcomes. You can lead a normal life.
So what is your recommendation? Suppose a young lady comes and says, doctor, I've got ulcerative colitis. Can I get pregnant?
Definitely.
Yes, the only clause you would say is
keep your disease under
yes,
control.
first get the disease under control and then get pregnant, because
Yes.
all outcomes of pregnancy depends on how good the disease is under control. So if it's not controlled, get it under control and keep it controlled.
That is the most important thing.
Venkatesh Prabhu is keen on knowing, can we be on biologics for long term? Yes, certainly biologics can be used for long term. There are patients who have been on biologics for more than a decade now, available both in our own country as well as in other countries. So they are reasonably safe from that point of view. The biggest problem about biologics in our country is the cost. I think that's something that we need to factor in. The second is some of the older biologics, there was an increased risk of tuberculosis and other infections. Now we've also become a little more comfortable using them. We know how to predict if they are going to get it, prevent it as well. And now there are biologics that are available which don't increase this risk of tuberculosis. So I think a lot of work is going on to get safer and more efficacious drugs for IBD.
Okay. So I think the most important crux of the thing is a good diagnosis, and for diagnosis we need to have a team effort like we discussed, and there are medications available, and like we discussed, good control of the disease with whatever options of treatment that is available to have a good quality of life. Anything else?
I'd like to ask you a provocative question. Can every gastroenterologist deal with IBD?
I think the most important thing is you should have a great interest in IBD. A gastroenterologist who has an interest in IBD is the best person, and not everybody.
Yeah, because now there is a subspecialization of gastroenterology, just like we have gastroenterologists who deal with patients with liver disease. There are gastroenterologists who deal with patients with pancreatic disease. There are gastroenterologists who deal with patients with IBD. So it's very important that you reach a center which has an interest in IBD, who are managing a lot of patients with IBD, has got a team to manage these patients, because only then can you get the best outcomes. Do you agree with me on that?
I totally agree. You need to have an interest in IBD to deal.
Because there are so many developments, and trying to keep up with those developments, you need to be constantly reading, constantly experiencing seeing these patients with their myriad problems and recognizing those subtle things that you need to treat.
Yes.
There are a couple of questions which are not directly related to IBD, and what I think, Kyle, we can do is we can take this up now. Maybe you could do this.
So Lakshmi Harsha says, why does irritation of my stomach and throat acid reflux lead to severe discomfort, especially after certain foods? And it leads to headache and vomiting. Lakshmi, we need to really look at you because this headache and vomiting and stomach and acid reflux can have an association. It can be a manifestation of migraine. We have a lot of patients coming to us and say, doctor, I have a lot of acidity. It causes so much headache, I vomit and I feel better. But it is actually the other way around. It's migraine. Like how migraine affects and causes your headache, it also affects your stomach and causes GI symptoms. So we really need to look at you, assess, take your history again, go examine you and find out whether this is really migraine leading to those symptoms or they're two different problems. So we really need to.
The other thing is, of course, certain foods we know can worsen reflux, and typically this is the coffee, aerated drinks, very oily food, very spicy food. Can cause reflux, and that may also end up in vomiting. So whether it's actually reflux disease or whether it's a variant of migraine is something that, as you rightly said, we need to sit across the table and resolve the diagnosis. This is a question from Pavitra. It says, I have 5 months pregnancy and feel that my stool is hard. Is this normal during pregnancy or should I address it?
Yes, there is a lot of hormonal changes that occur in our body during pregnancy, and slowing of the intestines because of that is a very well-known cause. Constipation is a little more common during pregnancy, which can be addressed initially with home remedies that we normally take. If it's causing a lot of trouble, we can put you on medications which will be safe during pregnancy as well as breastfeeding.
So something like harsh laxatives, you would not
No,
use.
that's
You
right.
maybe just increase the fiber intake.
Home remedies.
Or home remedies.
If you
Or,
don't respond to that, then I would definitely want to see you and put you on medication.
but yes, it's not a serious issue.
Yes.
It's something that's pretty common.
It's common, yes.
I think we've been here for a little over half an hour and maybe we should stop now.
Yeah.
If there are any other questions, please put them on to the page. We will certainly reply to you on mail or by message. Otherwise, thank you, Kyle. Thank you,
Thank you.
for this.
Thank you. See you.
Bye-bye.